The patient is 73-year-old male with 4 centimeter multicystic lesion at the pancreatic head. ESFNA will be performed by Dr. Ryouzawa.
Hello.
Good morning.
Good morning. This is a 73 male patient. He incidentally find the multilocular cystic lesions in the pancreatic head in abdominal US. And MRI shows a 4 centimeter cystic lesion in the pancreatic head. And now Nori and Stefan and James and Takao and my junior doctor Mizuide will help me. Now I'm in the duodenum at the duodenal valve, and now I show the. Can you see the multilocular lesions? And there are large cystic lesion and small cystic lesion side by side. And for the screening of cystic lesion like this, it is much important to find if there is a solid part or mural nodule. And now I check the cystic lesion, but you think is there any mural nodule or? I think these are septum, but there are some possibility of mural nodule. So for these cases, you think the contrast enhanced EUS is helpful or not?
I think so. However, exactly as you mentioned, this is just wall thickness of septum.
Yeah.
That not looks not through mural nodule.
And you think the contrast can differentiate the mural nodule and the thickness of the wall?
Or parenchymal pancreas? I don't think so. Yeah.
I think blood flow is more important to separate from a mucus ball versus the mural nodule. So, in this case, it may be questionable that contrast enhancement be helpful.
Oh, sorry.
In addition, there is no reimbursement for the pancreatic region in Japan. The sonazoid. That's too bad.
Yes. How about this part? Looks like mural nodule. No?
But what do you think when you use the contrast? Then if we have there more vascularity?
Yeah.
4 centimeter.
So, Dr. Ryouzawa, what is your decision-making process here?
Yes. So at first, the contrast enhanced EUS, and the another option is EUS FNA. But I think, especially in Japan, there maybe not so many doctors agree. This part, not mural. Not, okay, so contrast EUS, can we?
Let's try.
Okay, so we try the contrast EUS.
So
できる？
what do you
ごめん。
use in Japan for contrast?
ソナゾイド。
So the contrast enhancement setting is available, which is not available in the United States. Let's push a button. He activated the mode,
Hmm.
and then now the contrast agent is being pushed into the intravenous injection. So how many seconds to minute would you wait?
Usually now the flow coming already.
Usually, 20 seconds.
Mm.
After injection, 20 seconds, we can see a bubble. Already, oh yeah, already there. So.
So we're seeing more of a uniform enhancement of the wall.
Yes, yes, yes.
So as we suspected, it's more of a thickened wall than
Yes,
the
yes.
nodule.
Yes. Not nodule ね。ここね。
So would you describe the findings and
Yes, the flow is homogeneously coming to. And there is no findings which suspect mural nodule. And so,
Okay. How is the U.S. situation? So you want to do USFNA aspiration or something?
in our practice, most of, probably Rob can echo or chime in, but in this situation, we would probably do FNA. Some institutions do 19 gauge needle puncture with additional brushing from the inside, or sometimes Salvisio confocal microscopy. But I think that utility is a little still questioned, and adequacy is just mostly fluid aspiration and cytology evaluation. The problem is cytology is very low yield. So for now, it's diagnosis of confirmation of mucinous cyst is the main thing to exclude any of the possible high-grade dysplasia.
But for changing the therapeutic strategy would only help if we would find high-grade dysplasia,
That's correct.
and we see no really solid mass work.
Right. So with a 4 centimeter cystic lesion in the head of pancreas,
yes,
there's certainly the surgeon discussion with the surgeon for possible
yes.
indication is in a way. So unfortunately, most of the patient really wants a cytological confirmation if this is a mucinous cyst, which truly the risk is present. So we're sort of forced to take a sample.
Dr. Kami,
Yeah.
when you take sample, what do you measure? Like CEA, amylase, or I know you talked about cytology, but
Correct. So the first thing is to take a sample from the fluid and check for amylase and CEA. The second is a sample of the wall to get more cytological evaluation.
But you know, when we have then the CAA, it doesn't really help us for the therapeutic decision.
Yes.
What do you think?
Yes, it is reported that CEA level doesn't reflect the malignancy.
I totally agree. We can distinguish the serous cyst adenoma from the mucinous cyst adenoma by viscosity of
Viscosity,
the liquid.
yes, right.
It is a good so indication. However,
We know already, or?
yeah, but right.
Okay, yes.
Okay.
And anyway, this is 4 centimeter. So, is there any indication for the operation, James?
Well, if you refer to the guidelines, there was a revision of the Fukuoka guidelines last year published in Pancreatology. For a branch IPMN, anything greater than 3 centimeters should be considered for resection. So I understand the patient is a 73-year-old.
Yes.
And you are not seeing worrisome features. So this is highly controversial.
So, Dr. Ryouzawa?
Yes.
So, very rare, but similarly, the macrocystic type, serous cyst adenoma, happens. So, how to distinguish, how to differentiate?
It is very difficult. It is very difficult. But I think that this side-by-side structure means IPMN.
Really?
No?
I guess, for example, central scaling or something.
Yes,
show-
or
Yeah,
calcification.
yes, central scare.
Mm.
But I think almost mostly the IPMN,
Yes.
but rarely, but we
Yes.
encounter such cases. At that time, the FNA aspiration is very helpful.
You want to check
to
the
avoid-
viscosity?
Yeah, to avoid big surgery, pancreatic duodenectomy.
Mm.
So the CA less than 5 is almost exclusively for non-mucinous cyst. If that happens, that's helpful. But if it's in between 5 to 122, it's not going to be too helpful. So once the CA is high, we can say most likely mucinous cyst. But again, the malignancy or a high risk feature is not measured by the CEA. So that's a difficulty.
But when
Yes.
when we focus now on the imaging, we can say, okay, this tumor is over the guidelines with 3 centimeters, but we have no nodules. The contrast was also important, I think, because it showed regular vascularity. And we have a patient who is 75 years old. So now the question is, should we confuse the patient more with the EOSFNA? Because when we have now high CEA,
Yes.
Okay, Stefan, how long follow-up time in this patient? For example, 1 year regularly CT-MRI or US or something.
we discussed this before a little bit. I think
Yes.
somewhere in the guidelines is written 6 months, but I think I would follow up the patient in 1 year, and I would also check the lipase regularly, maybe after 6 months, and then see from there.
Yes, it depends on the age of the patient. If the patient is younger, I want to check every 6 months. But 73 years old, so I think every year MRCP check is enough.
May I ask you, how is the situation with the surgeon? In Germany, Switzerland, we have very strong surgeons, so would be difficult for me to convince them to wait and see. How is it in Japan?
How?
So in Japan, the surgeon is very kind. So often we discuss with the surgeon what is the best for the patient. Sometimes we say so strongly, no more the examination and go to surgery. It depends. It depends on the situation, institution.
So now in our institution as well, the question comes when how long you're gonna wait. If you keep waiting and he becomes 85 and now shows the signs of malignancy, was it justified to wait? Especially so many people have so many comorbid conditions. So if the patient's healthy, there's an indication probably surgery earlier would be more preventative. So there's another argument you can do. The surgery early in age is better, or just wait until it declares that this has a malignant potential.
I guess it somewhat depends on the surgical results of a Whipple to an institution. So if we do very safe Whipples, I think we've not had a loss over 70 cases. So it somewhat depends on the surgical results. So I guess it's very important.
And how long should we follow up this patient? Forever or 5 years? Then, if there is no change, can we stop?
You ask the question of the surgeon. Who will ask us?
But so you know the AGA,
Yes,
so guidelines so recommend only 5 years.
5 years,
After
yes.
that, so no more. So how about?
How about Nori?
So that made with the severe criticism from many of the thoracic endoscopists. So many endoscopists, U.S. sonographers, doesn't follow this recommendation.
Okay.
And the new ACG guideline has been published as well to counteract this argument.
So, as a conclusion, this IPMN is a branched type. The size is 4 centimeter and with no definite mural nodule or solid component. So we can follow up this patient. And the age is older, so I recommend once per year's MRCP follow-up. Okay?
And no FNA.
No FNA. Okay.
Okay.
So we can finish.
Okay, thank you for
Thank you
a
very
great demonstration, and thank you for a great discussion.